Okay, I will hand it over to Lori now.
Oh, well, all right. Okay. Hi, thank you so much. I'm super humbled to be in this amazing group of people working on power and empowerment. I'm going to share a little bit about just a very practical way that we've used community-based participatory research in our work here at the in New Mexico. So I just want to make sure I have my time right so that I can stop appropriately. Okay, so so basically I will share a little bit about how we use community empowerment and health equity approach during the time of COVID. I am a physician, but I'm also a public health practitioner. And so I have used as a map. As physicians, I think we are not trained to see communities. We're trained to see patients one at a time. And the community-based participatory research map has actually been very, very helpful for me as a clinician to really understand how to actually map out how we can work towards equity. I love this definition by my colleagues, Nina Wallerstein, Duran, Etzel, and Minkler, that CBPR is a collaborative effort between multi-sector stakeholders who gather and use research and data to build on the strengths and priorities of the community and use multi-level strategies to improve health and social equity. That definition is what kind of drives this CBPR conceptual model. I love it because it's one page and it's also on the CBPR Engage for Equity website that I'll show you. But basically what it does is it brings all the conditions of a model to say, like a lot of the things that you guys have been talking about, it brings it into one model where you're identifying, for instance, priority health outcomes and then linking them to the context, understand the context, and recognize that context influences how we partner and then influences our interventions, whether they're community-centered and if you have partnership synergy or appropriate research design. It looks really complicated, but it's actually not. Like if you go down to each one of the boxes, there's context, and the data has shown from this research that certain contextual factors, partnership factors, intervention and research factors lead to improved outcomes. If you look at the whole model, it really comes down to four main blocks of domains: context, partnership, intervention and programs, and health and social justice outcomes. Here's the tools for Engage for Equity if you want to look more at these tools. The thing is that it's all based on Paulo Freire's empowerment work. So really defining empowerment as a dialogue process where people are participatory actors. What's beautiful about the model is that it is just like Teresa is saying, it's a plan, do, study, act model, right? It's the whole praxis of listening, dialoguing, taking action within a community, and doing it in a rapid cycle is how we've been able to do it, because you think sometimes CBPR takes a long time to build trust. And in my experience, you use it in places where you already have trust in the community, and you can do this rapidly, especially in the time of COVID. So I'm going to share with you a little bit about what we did in the time of COVID using the CBPR model. The setting that I work in is I'm a physician in a large congregate shelter for people experiencing homelessness. So you can imagine this shelter is about a half an hour away from this actual city. So people are being bused in and out of the shelter every day. And if you can imagine that, that's just for COVID, that's a high risk section for COVID. And COVID, you know, the people are in congregate settings, they're clumped together. And right now we're facing asylum seekers, and we're actually going to have to figure out what to do with this situation. What we learned from this experience is actually going to help us with the asylum seeker situation. So what we found was that when we started working together, we were already a partnership that was a multi-sector partnership. We actually gave ourselves a name during COVID. It was like the Corona Crushers that brought us all together. It was a community coalition of multiple stakeholders: city, state, university, medical reserve corps. We took everybody to try to address the situation that, you know, and this is an amazing group of people that we got to work with every day to try to look at the strategy, to envision what it would be like to serve this community. So what we did was we used the CBPR methodology, starting with the outcome. The community came together and said, with the people experiencing homelessness, what do we want to do? And everyone was scared. The people experiencing homeless were like, how do we do this? How do we stay apart? What do we do to keep ourselves safe? And so we all rallied around this one health equity outcome. They're disproportionately affected. What we did was not look at just outcomes that were health outcomes. Yes, we wanted community transformation, improved health like decreased COVID, improved access, but we were also looking at intermediate outcomes like what power sharing were we doing to improve, sharing inside this multi-sector group and the community? What kind of sustained partnership were we doing? What policies were we changing? And were we actually helping empowerment outcomes such as individual and agency capacity? We then looked at the context and say, this is what's going on in the context in the area. There are certain things in this model that have been looked at the data. It's a 14-year NIH study that found that, if you have social and structural inequities, if you have capacity in the community, you're looking at community strengths and readiness to partner, that's actually been measured, that improves outcomes. Good policies and politics improve outcomes, and a history of trust and collaboration. And we actually have a little partnership practices guide that actually the partners take a partnership survey together to look at these actual things to say, okay, what things are we doing well on and what things can we improve on? We look really importantly at partnership. So how are we partnering together is so important. Who we are matters, how we partner matters. So looking at certain data like deliberate communication, integrating community knowledge and fostering trust led to better outcome. How our partnership is structures that facilitated empowering practices also were helpful. And we have this in this partnership data report where the different partners take this short survey, and it shows that certain things like % of dollars to community, final approval, control of resources, all improve outcomes. So it's a simple thing. What we really were driving towards was like, let's look for something simple that communities don't need universities to do. They can do it on their own, right? So what we did was simple things. We listened to each other, we coordinated daily, we fostered trust and built community and facilitated equity and power. One of the things in a COVID kind of setting is that COVID it can spread really fast in a shelter. So at first we were like doing the whole thing, like, let's all work together and do this thing together. But actually we needed to have really clear roles and responsibilities. And there are certain organizational practices that we had to do. The program, how we do things is just as important as what we do. So we worked alongside the shelter staff and CHWs, and we looked at really clear empowering practices like how are we building capacity? How are we integrating local knowledge? We had very clear elements of what we were doing: screening and testing, isolation, social distancing, early medical care, and partnership. They were all key elements of our response. We developed quarantine areas together with the community, with the people experiencing homelessness. And this is one of their pictures of one of the people in quarantine. He was feeding this little bunny every day, and just like really a humane process, right? We developed quarantine pods and people really got feedback from them. We did a feedback co-learning process where we would get data from the community, like the homeless shelter residents, and then we would improve it all the times. So things like improving their food and improving, how we treated them in the quarantine. Like some people weren't treating them nicely. So we'd be like, hey, you need to treat people really nicely. And things changed. People began to quarantine better because it's not just about the COVID, it's also, and testing, it's also about helping people quarantine so they don't spread COVID. So we developed pods. We actually looked at long-term things as well. So we not only worked on short-term things, but with the COVID funding, looked at wellness hotels for transitional housing. So really focusing on both the short-term and the long-term. The community was like, I didn't know who needed to wear what kind of mask. So with our medical students and undergrads, we developed, from the data we got, developed interventions that were helpful and easy to understand. And so what was the final impact of these partnering practices? We had these practices. If you look at empowerment and CBPR, this is an article by Wallerstein. a lot of the things I just talked about, like emancipatory power in the context, deliberative communication and partnering practices, valuing community knowledge and co-learning processes for these social justice and equity outcomes is how you kind of measure these things. So here are the different impacts we had. Look at this amazing impact. We had a huge outbreak in October here, and it was actually comprised most of the state's positivity rate that day. We regrouped as a team. We got DOH to give us rapid Binax testing to allow us to test people rapidly. And we were able to, as a team, as a community, reduce rates in the shelter so that now we're like much lower. It's actually safer to be in the shelter than in the community. Right now, our positivity rate is lower. We use the CBPR efforts to align our efforts. So you could see that we shared the outcomes. We looked at context together. We looked at who was missing in partners and developed programs together. And then, the impact 3 was we developed a actual protocol that can now be used in other shelters and congregate settings and asylum seekers. We did that together. We built capacity in our students and our shelter residents. And so basically at the end of the day, if you analyze context together, do partnership, improves program, which then leads to social equity outcomes. This is a pathway that shows how you can do that with the data. And then this is the end. Just at the end of the day, CBPR is about showing up, being who you are, listen, believe in social justice, and take action for social change. And I love the model because it's simple and you can really use it in a very simple way.
Wow, thank you so much, Laura. I didn't think you'd get through all 40 slides, but you did it beautifully. And just really appreciate such a concrete example of the application of the CBPR model. And I think one of the things that we struggle with COVID is that we're always in this rapid response mode, and you showed that you can really do it in a very good way that really engages community and really empower them. So thank